Hi guys, am I live? Can you all see me and hear me? Just let me know if I'm live yet. Yeah, I think I'm live. All right. You know how it is with me and YouTube. I don't know, every time I have a YouTube session, it's like there is always a fear of impending doom and that I will not connect and that there'll be iPad issues. And every time there are some new permutation combination of issues which occur. But hopefully I am live and you can see me and you can hear me fine. So before we start with the previous year questions, we done one of these classes a couple of days back, and we are gonna be covering the rest of the previous year questions in two parts today, in two half-an-hour sessions. Half an hour on YouTube and half an hour on the app is what we're gonna be doing, and we'll be finishing off radiology PYQs. And because you wanted this for other subjects, so we'll be starting a series wherein we'll do a rapid fire previous year questions of all of the recent NEET and fmge papers, subject wise. From first on first we'll have two more classes, one will be on micro and one will be obs gynae, so you can quickly revise those subjects and appear for the PYQs, or you may just appear ki dekhte hain, if I just appear in NEET without preparing, where will I stand? So if you want to see that kind of assessment, you can just show up. Okay, so this is for the achievers batch on the plus program, wherein we'll be having an extensive rapid revision, TND, and doubt clarification by all the educators on the platform. So this is there, and we also have Prof 5 subscription, so you can check this out. All right, so then let's begin where we left off. The PDF is already there on the group. It's already there. It's the same question PDF which was there last time, so we are just continuing with it. Nothing has been changed, so that you can just mark your answers in that PDF. You can find it on the channel in case you are looking for it. Radiology, no, NEET PG with Dr. Zainab Vora. All right, so you can find that on the group. It will be pinned. Chalo, come on, tell me what is the answer to this. 25-year-old female with primary infertility, ultrasound findings of uterine anomaly. So to confirm the diagnosis, which of the following will you use? So uterine anomaly, remember, for confirmation investigation of choice, we will go for, so when they ask you, so this is again a question wherein you have to look at the options and you decide your answer. So investigation of choice technically would be 3D ultrasound or an MRI that I would use to confirm. But again, here they are not in the option, so we go for directly for the investigation with the highest accuracy, which is the gold standard, which is diagnostic as well as therapeutic, which in this case is a combination of hysteroscopy and laparoscopy. HSG, remember, is never ever something that will be used to confirm it. There's an incidental diagnosis that is picked up on HSG for uterine anomaly. They will never confirm anything. Just laparoscopy, can I do that? Just laparoscopy will not solve the purpose, because I want to see the inner contour, I want to see the outer contour. Only when I see both of the contours can I decide what is the anomaly. That is why it's hysteroscopy and laparoscopy, which is gold standard, which is diagnostic as well as therapeutic. Just TVS will again not solve any purpose. We need a 3D ultrasound or an MRI to confirm. All right, so I hope this is clear as far as Mullerian anomalies. Every year you get one question on Mullerian anomalies. In the last NEET we had three questions on Mullerian anomalies. Okay, so itna chota sa topic with three questions, you cannot leave it. We have done one MKT on Mullerian anomalies. You need to see that. This is for everybody. Come on, next question. 35-year-old male working with hammer and chisel had an accident and a foreign body enters the eye. Which of the following investigations will be detrimental? Again, this is an example of a question wherein you can get this wrong if you jump to the answer. Kya investigation karenge foreign body? No, this is asking which is detrimental, which is contraindicated. So MRI, contraindicated. Remember this about foreign body, any metallic foreign body or any foreign body. Otherwise, the initial investigation, the first thing you will do is going to be an X-ray. The investigation of choice is going to be a CT, a non-contrast CT, because metal is even whiter than the bones. You do not need contrast to look at it. NCCT. What is contraindicated? MRI. Magnetic field and metal do not go well together. There will be impact, there will be damage to the patient. You will never ever do MRI in a patient with suspected foreign body. All right, so this is something which is very important. I hope there are no doubts here. Again, foreign body is such an important topic. Every time you will get one odd question. Either there'll be an image of a foreign body in the esophagus. In the last class, we had seen round dikh raha hai, it is in the esophagus. Slit dikh raha hai, it is in the trachea, right? I hope you guys remember that. All right, next question. A patient is diagnosed with spinal TB. He has a swelling in the left groin and limb attitude is in flexion. Identify which of the muscles is responsible. So A, B, C, D. Out of this, which of the muscles do you think is the muscle which is responsible for his flexion deformity? So this is a kind of a question which is ortho, radio, anat, all in one. Yes, so what you see here is this psoas. The moment you think of TB, you think of psoas abscess. It is iliopsoas which can cause a flexion deformity, isn't it? So this A muscle is definitely psoas. What is the muscle marked B? Anybody can tell me what is the muscle marked B? I'll give you a hint. Eventually it's gonna combine with psoas and attach at the lesser trochanter. What is B? It is the iliacus muscle. Yes, so A is psoas. B is iliacus, and what about C and D? So C and D are attaching on the GT, as you can see, greater trochanter पे attach हो रहे हैं. So this is basically gluteus muscle, isn't it? So the outer one which is not attaching at GT is gluteus maximus, and the inner one which is attaching at GT is the gluteus medius. Okay, so these are the muscles. Is the CT anatomy. Bones are wide. This is a coronal section of CT. Okay, so psoas, and the test which is used to assess what is the fixed flexion deformity, again a very important ortho question. It is Thomson test or Thomas test. It is the Thomas test, right? So everything Thomas is very, very important as far as exams are concerned. Okay. So Thomas test is assessing fixed flexion. You will see that one person is lying down and you ask him to flex one limb. If there is flexion deformity, you will have the other limb also being flexed to account for that flexion fixation of the flexion. All right, so that is how the Thomas test is performed. Apart from that, we have a Thomas splint as well. So Thomas splint is used for fracture of shaft of femur. It looks something like this, if the if this makes sense. All right, so it looks like this. There's a curvature here. All right, so that is how it looks. There is one ring here, and then the pair goes, the leg is gonna go inside it. Okay, so this is how the Thomas splint looks. We've seen this, right? What is the Thompson test? The Thompson test is used for Achilles tendon tear. It is used for Achilles tendon. Understood? No? Yeah. Achilles tendon tear. So you want to see as many classes of me when you can understand this image. You have reached pro level when you have when you can put an image to this, when the exact Thomas splint comes in your mind when you look at this diagram. That is the level we want to reach, है ना? Yeah, Thompson test is for Achilles tendon tear, wherein you ask the person to do dorsiflexion. The person will not be able to dorsiflexion. All right, so Thompson is for Achilles tendon tear. ठीक है, so ये हो गया हमारा this question. Fine. Next, 60-year-old female with increased bowel sounds. She reveals dilated small bowel loops and air in the biliary tree. She has history of hysterectomy 2 years ago. What is the likely diagnosis? So lots of histories have been given which are confusing. And if I was to just read at this question, I would think of a few things. Increased bowel sounds means intestinal obstruction. They are only trying to confuse us with history of hysterectomy 2 years ago. Agar history of past history of surgery hai, that is likely to be small bowel obstruction because of adhesions. However, so dilated small bowel loop still fits. However, air in the biliary tree will not be explained just by adhesions causing small bowel obstruction, isn't it? So when you have air in biliary tree, pneumobilia, what do you think of? You think of the Wriggler's triad, and the Wriggler's triad is seen because of gallstone ileus, right? So we have a gallbladder stone which has gone into the small intestine through a fistula, likely with the duodenum. So there is likely a cholecystoduodenal fistula. वहां से stone गया, stone has got an obstructed at probably IC junction, which is the narrowest part, and it's leading to upstream small bowel obstruction. So what is the Wriggler's triad? You have a gallstone, yes, which is impacted in the small bowel. So you have gallstone likely at the IC junction, you have small bowel obstruction, and because of that fistula which had happened, air has gone into the biliary tree. So you have pneumobilia. Okay, so this is how You do not jump to the diagnosis. History of hysterectomy can just be small bowel obstruction, but because of air in biliary tree, we will rule it out. Okay, yeah, this video will be available later, like all other videos. Okay, on the app also. All right, so this is how we are gonna approach this question. I hope this is clear. Okay, is this video blurred? No, you need to change, Asmita, your settings of YouTube. You need to go to high res. All right, so 55-year-old hypertensive male with acute chest pain, loss of consciousness, diaphoresis with unequal pulses and bilateral upper limbs. Again, lots of things happening. Hypertensive है, ठीक है. Acute chest pain could be lots of things. Loss of consciousness means something is wrong with carotid as well. Diaphoresis with unequal pulses and bilateral upper limbs. Very, very important history. Anytime you have unequal pulses in bilateral upper limbs, there are few things which come to your mind. Something not in an emergency setting, a female, a young female, think of Takayasu arthritis. An older male, hypertensive male, emergency like this case, we think of aortic dissection, not aneurysm, aortic dissection. Coarctation of aorta? No, not unequal upper limb. It will be unequal upper and lower limb. So you see a brachiofemoral delay where upper limb is pulsating and lower limb is feeble, right? So coarctation is not a consideration. We are just playing between these two. So here, hypertension, emergency, we're thinking of aortic dissection, and that is why the best investigation to reach the diagnosis in emergency setting, T. So unstable patient, T. If CT angio was an option here, that would be a better answer, but that is not in the option, right? So TE, CT angio if there is a stable patient. Cardiac enzyme, so we are not, even though there is diaphoresis and acute chest pain, MI will not be explained by unequal upper limb pulses, right? So that is why I am ruling out MI, and MRI and X-ray I am anyways ruling out, because MRI in an emergency never, pehle hi rule out kar do. X-ray will not help us reach any sort of a definitive diagnosis in this case. So this is how we will approach, okay? Previous question, ERCP? No. Now gallstone has reached small intestine, right? So now you will need to explore the patient and remove the stone. अब ERCP से नहीं निकाल सकते. Okay, चलो next. 35-year-old male with fever and uneasiness since 2 to 3 days, presents to the ED with acute pain abdomen. Oath question. The moment you see acute pain abdomen and you see ki image is a chest x-ray, no matter how tiny, how blurred, how ganda image is, the moment you see pain abdomen and chest x-ray being given, Sida your eyes should go where? Your eyes should go below right diaphragm, not left, below right diaphragm. And if you see black air, that is perforation, that is pneumoperitoneum. So this question will always come. So pre-test odds of this question coming are very high. Isiliye the moment you see pain abdomen, chest x-ray, think it is perforation, look for air under diaphragm, confirm diagnosis and move on. All right, so do not waste any time on this question. No complication, always this will come. So perforation, या तो diagnosis पूछेंगे या तो they'll ask you what is the next step. Next step पूछते हैं आजकल, and they will give you options like IV fluids, exploratory laparotomy, CT. Will you do all of them? Will you do 2 of them? Will you do 1 of them? IV fluids, never refuse. हमेशा ही resuscitation करना है. Exploratory laparotomy, yes, this is a surgical emergency. CT scan, not needed. If X-ray is telling me the diagnosis, why waste time confirming the same thing again, right? So if X-ray is normal and clinical suspicion is high, then we go for CT. CT is the investigation of choice. It's the most sensitive for perforation, yes. But if X-ray only is showing, then no need to waste time, isn't it? Do you want to intubate this patient? अगर option में दे दिया intubate, airway is very important. You want to intubate this patient? No, this person's airway is not under threat, right? This person is probably screaming कि मुझे पेट में दर्द हो रहा है. If he's screaming, means his airway is intact. Do not intubate this patient. Even though it's A, B, C, D, E, you don't always have to intubate, right? Secure airway. If airway is secure, move on. Okay, so this is how we do not get confused with easy things. हमें आता है, but we get trapped in these tiny things which are not worth getting trapped in. All right, so ये सीखना है हमें. Okay, moving on. 40-year-old male with acute pain abdomen, presents to the ED. One more emergency. Fluid-filled lesion in the epigastrium. What will be the abnormal investigation? So when we have हाँ laparotomy में करना, मतलब that is your anesthesia thing, right? happily frustrated. You get my point? It's not an initial thing. पहले intubate करके OT लेके जाने की जरूरत नहीं है. Okay. 40-year-old male with acute pain abdomen, fluid-filled lesion in the epigastrium. So you're thinking of pancreatitis. In pancreatitis, when you have a fluid-filled lesion, that is pseudocyst. The most common complication of pancreatitis is a pseudocyst, right? So abnormal is lipase, right? Not GGT, not bilirubin, not CA. Okay, again, if you do not understand what is going on, bilirubin, GGT would be raised together, right? You have to choose one answer. तो दोनों अगर obstructive jaundice भी है, both of them would be raised together, so you can rule it out. CA is a tumor marker. Usually a fluid-filled lesion will not be tumorous. A cystic lesion is not tumorous. You can rule it out. So exam में नहीं आता, C options देखो where they are pointing towards, and that will give you a good clue, all right? So this we have to learn how to approach questions we do not know. 30-year-old man post RTA with flank ecchymosis and stable vitals. Which of the following investigations is the best to localize site of bleed? So anytime they ask you best localize in trauma, stable, it is CECT. Can never be X-ray. RGU will not help us. It will help with urethral injury only. So ultrasound and CCT. By ultrasound here we mean EFAST. So if they ask you initial, any patient, stable, unstable, it is EFAST. If they ask you investigation of choice in a stable patient, investigation of choice to see what organ is injured, it's going to be CCT, because EFAST will only tell us if there is hemoperitoneum or not, whether there's bleeding or not. Are you guys getting this? So this is about it. When we have flank ecchymosis, what are we suspecting? What sign is this? This is the Gray-Turner sign, right? So we are suspecting that there's some sort of retroperitoneal hemorrhage. It could be pancreatic trauma, it could be renal trauma, it could be any other cause of retroperitoneal hemorrhage. If there is umbilical hemorrhage, ecchymosis, it is Cullen sign. So U for Cullen, U for umbilical, right? So this is how we will approach this. 13-year-old boy presents to trauma center after skid injury. He is unable to pass urine with blood at meatus. What is the next step? So urethral trauma, unable to pass urine, blood at meatus, clinical marker of urethral trauma. Next step technically has to be RGU. I cannot find that in the option. Let me rule out. Can Foley's be an answer? Never. Contraindicated. Foley's is needed for performing a micturating cystourethropy. I need to put Foley's, I need to put contrast. Agar Foley's ही नहीं डाल सकते, MCU is contraindicated. Is there any role of CT for urethra? Never. So I am left with only one option. So when RGU is not in the option, next step, go for SPC. So when RGU is not in the option, SPC. If RGU is in the option, that is the investigation of choice. That is the next step. If that is not there clinically, I will assume that it is urethral injury and we will go for suprapubic cystostomy. Are you guys understanding? Same question AIIMS has modified and asked so many times. अगर यहाँ पे RGU is not in the option, SPC ही है, and they give you that the bladder is not palpable. Can you perform an SPC? No, you cannot perform an SPC. So in this case, you want to wait, all right? People are marking wait and watch for everything because that is one repeat question. No, only when RGU is not in option, SPC करना है, but bladder is not palpable, in that case you wait and watch. I hope that is clear and you will not ask every urethral injury patient to wait and watch just because that is one repeat question. Only when bladder not palpable and SPC. अगर RGU option में है, we will go for RGU. Remember, RGU option में है, next step always RGU, not wait and watch. Okay, I hope that is clear. 54-year-old male with dyspnea, elevated eosinophil count. CXR shows miliary mottling. Miliary mottling. So miliary mottling, we think of TB. सीधा सीधा मन तो हो रहा है miliary TB मारने का. But will it have eosinophil count raised? No. So I will rule it out. Will chronic HSP Chronic hypersensitivity pneumonitis will not show you miliary mottling. It may have eosinophil count which is raised, which is also very unlikely, but it will have a fibrotic sort of a picture. So this also I can rule out. Asthma will not show me miliary mottling. Asthma will have a airway component. So there will be air trapping. There will be hyperinflation. No pulmonary opacity. So the answer by exclusion is TP, and yes, tropical pulmonary eosinophilia rarely can have miliary mottling, and it will definitely have eosinophil count which is raised. In fact, the name is telling me the answer. Tropical pulmonary eosinophilia. So apart from TB, what are the other causes of miliary opacities? These tiny bilateral nodules, most important TB. Apart from that, vascular, because TB, miliary TB is what? It is hematogenous spread, right? So TB. Apart from that, very vascular metastasis, something which always mimics tuberculosis. Histoplasmosis can have miliary mottling. Apart from that, if we have mitral stenosis and you have hemosiderosis, lungs में blood आ रहा है, pulmonary hemosiderosis can have miliary mottling, and something that we have just learned is tropical pulmonary eosinophilia, and very rarely healed varicella can give you miliary mottling. Varicella जब heal हो जाएगा तो miliary nodules आएंगे. Okay, sarcoid, no, sarcoidosis doesn't give you miliary mottling. Okay, sarcoid gives you perilymphatic nodules. Okay, so sarcoid is gonna give you perilymphatic nodules predominantly in the upper lobe predominant perilymphatic nodules. Sarcoid will mimic silicosis. Remember, sarcoid silicosis go together. Both of them will have upper lobe predominant disease. How do you distinguish? On the basis of history. ठीक है. HSP is hypersensitivity pneumonitis. Hypersensitivity pneumonitis will have a different picture altogether. Here what you have is a component of small airway. Small airway में inflammation है. So we will have air which is getting trapped. We will have ground glass opacity, and we will have centrilobular nodules. Very core radio words I have thrown at you, but you don't need to know this. You just want to know that it will not have miliary mottling. All right, it will have centrilobular nodules, ground glass opacities, and air trapping, and this appearance is called as a mosaic appearance. All right, कुछ black दिखेगा, कुछ white. Very plain language में if I put, if you look at the CT of this patient ना, कुछ black area लगेंगे, कुछ white. थोड़ा ground glass होता है, थोड़ा air trapping होता है. So when you see black and white mosaic sort of appearance, that is how hypersensitivity pneumonitis appears. Okay. Yeah, choriocarcinoma, RCC, any vascular metastasis, basically follicular thyroid CA, all of these things. Okay. 35-year-old male with RTA with BP 90/60. What is the next step? Anytime they ask me next step, चाहे वो BP stable है, unstable है, कुछ भी है, next step is always EFAST. Never ever MR, not CT as the next step, and DPL is not performed now. If you have EFAST, diagnostic peritoneal lavage is not done. Thank you so much, Shubha, for your kind words. DPL is not done if you have EFAST. DPL is very diagnostic peritoneal lavage is not performed nowadays in extreme cases where you have no ultrasound, you have no radiologist, you have no doctor, no radiologist, no EFAST, then you can do DPL. Okay, fine. Next. 10-year-old child with emergency with sudden onset vision loss in bilateral temporal fields. The moment you read this, you can localize कि lesion है optic chiasma में, right? Optic chiasma compression by temporal hemianopia. बच्चा है. I don't even want to look at image. I want to look at image. I don't need to look at image. Do I need to look at image? No. But I know radiology, so I will look at image. I will look at image and I will see that there is a black cystic mass, and you can see that there is white calcification. So everything is screaming in one direction. Child, cystic, calcification, all C is telling me diagnosis is also C. It is craniopharyngioma, right? So craniopharyngioma, child tumor, optic chiasma, compression, cystic tumor with calcification, machine oil, wet keratin pathwise. This is craniopharyngioma adamantinomatous type. Pituitary adenoma, elderly patient, non-cystic. Rathke cleft cyst, yes, it is a cyst, but it will not be present in a child. It will never be so big. It is always within the cella, so it will never present with optic chiasma compression. Meningioma, again in a child, very unlikely, and it is not cystic. Okay, Rathke cleft cyst is just one remnant. So Rathke pouch जो होता है उसका remnant से one cyst is there, very small cyst within pituitary. It is usually located in adults. Okay. 8-month child after vaccination, incessant crying and legs drawn up. Barium enema is shown here. So pain in the child after vaccination, barium enema showing you this coiled spring appearance, claw sign. This is intussusception. You can't get this wrong. Intussusception. All right. This can't be malignancy. No Meckel's, no volvulus. This is intussusception. Vaccination hai, diarrhea, any lead point 6 to 8 months. Ileocolic intussusception, most common. Treatment of choice, gold standard is barium enema. It will treat any enema, can treat and reduce the intussusception. Identify the investigation and diagnosis. Is this RGU? Is this MCU? When you see ki outer part hai, outer part of the uterus, not uterus, urethra, anterior part of the urethra is seen, and you are seeing that contrast is just barely passing into the bladder. This is not MCU, this is RGU, right? So this you can rule out, it is not MCU, this is RGU. What do you see? There is a narrowing. Where is the narrowing? Is it in prostatic urethra? No. Remember, we will never comment on posterior urethra on an RGU. It will always appear narrow. So you can never ever say कि ये तो narrow लग रहा है, ये stricture है. No, we will always diagnose only anterior urethral stricture on RGU. Remember that, only anterior. And what you see, this is the penile urethra where it takes a turn. It is the bulbar urethra. So there is bulbar urethral stricture RGU. Okay. Remote afterloading, theoretical question. What is remote afterloading? It is done in brachytherapy. So what is brachytherapy? Where you embed, for example, prostate mein jaake you want to put these radioactive isotopes. Now if I am a person who's putting these radioisotopes, will I also get exposed simultaneously? हाँ, so I don't want that exposure. So for that, what we do is पहले ना मैं जाके ऐसे pellets, empty pellets I will go and put, and then I will have one robot come and put within those pellets the radioactive isotope, so that nobody gets exposed except the robot, but we don't care about robotic exposure. So that is why remote afterloading is done, which is brachytherapy. So remote afterloading, बाद में जाके load करना, is done in brachy. Brachy means close to the tumor. Okay. Stereotactic radiosurgery is gamma knife. Gamma knife is done for, which is membranous part. This, the moment you have bulbar which gets over, this part here is the membranous urethra, and then you have the prostatic. Remember, posterior urethra हम कभी भी comment नहीं करेंगे on RGU. It will always appear narrow. I only have to see if it's continuous or not. ठीक है? हाँ, so this is gamma knife. Teletherapy is from a distance. And what is cyber knife? Cyber knife is the other type of gamma knife where you don't need a helmet. It is for the rest of the body other than the brain. Okay. What is the likely diagnosis? Very baby question. When you see that there is a posterior diverticulum, these are the vertebra, this is Zenkers. In case this was anterior and below cricopharyngeus, so this narrowest part is the cricopharyngeus. This is above, this is below and anterior. So below and anterior is Killian-Jameson's diverticulum. Above and posterior is the Zenkers diverticulum. Sliding hernia will be seen when distally we are having stomach come up into the thorax, and Schatzki ring will be a circumferential narrowing. You will see something like this. ऐसा एक रिंग आ जाएगा, circumferential narrowing. You will see this bilateral circumferential narrowing. That is how a Schatzki ring appears. Okay. Radiation dose monitoring in occupational worker, very easy question. TLD, thermoluminescent dosimeter. A grid is something that we use to increase the contrast of the image. All right, X-ray का contrast use करने के लिए, where if this is the image receptor and this is where patient is lying, between patient and image receptor I will keep a grid, so it will absorb any off focus radiation. जो भी टेढ़ा मेढ़ा radiation है, this grid will absorb. So only good focused radiation will reach the image receptor and I will have a nice quality image. So that is the purpose of grid. Collimator is when you, if this is the X-ray tube, यहाँ पे if I want to image the abdomen, the collimator will limit the beam to only the abdomen. So the beam limiter is called the collimator. And what is linear accelerator? Linear accelerator is something that we use in radiotherapy. All right, so what generates the x-rays and the electrons for radiotherapy? That instrument is called linear accelerator. Okay, so this is about TLD. Yes, we use lithium fluoride or calcium sulfate for TLD. It is sent every 3 monthly for reading and we wear it below the lead apron. Lead apron pehna uske below, under, at chest level we wear TLD. So these are all possible questions from this. 35-year-old female presents to you with history of nausea and vomiting. IVF. The moment you see IVF, pain abdomen and 2 ovaries with very large follicles, this is OHSS, ovarian hyperstimulation syndrome. Can same appearance be seen in theca lutein? Yes. So if you have history of molar pregnancy, snowstorm appearance hai, same appearance can be seen with theca lutein cyst. PCOD will have very small, ovaries will be bulky, but the follicles will be very small. Mucinous cyst adenoma can be cystic, can be solid cystic, but it will have some sort of solid component here. Okay, so this is how we can rule out. One of you asked lead apron ka thickness. So lead apron, remember, most common thickness is gonna be 0.5 millimeters and the minimum thickness is 0.25, right? So minimum thickness lead apron 0.25, most common 0.5. Okay, last question and then we will close and we will meet on the app. What is the sign which is shown in the image? So this is where recently we were discussing varicose veins somewhere. Yeah, so in varicose veins, we will see when we are evaluating varicose veins, this is the saphenofemoral junction where you have the great saphenous vein. So this is the GSV which is entering the common femoral vein and you have the artery here. So this saphenofemoral junction is called as Mickey Mouse sign. Okay, so this is saphenofemoral junction. We evaluate this when we are evaluating for competence, SFJ competence in varicose veins. Okay, if I were to check for DVT check करना है, I will compress with my probe. I will compress and what will I notice? That ये दो structures, vein structures will get compressed but artery will remain as it is. So that is how we diagnose DVT. Compressibility is normal. Okay, Stemmer's sign क्या होता है? What is Stemmer's sign? In lymphedema, when you will see कि non-pinchable, non-reducible है, तो that is seen in lymphedema. That is the Stemmer's sign. String sign तो हर जगह मिलेगा. You will see that in CHPS there is narrowed pylorus. In IC junction narrowing, it means terminal ileum narrowing. In TB and Crohn's you will have string sign. Loads of places. Tilosine कहाँ पे मिलता है? Tilosine is seen in mesenteric cyst, right? So in mesenteric cyst, you will have that it moves 90 degree to the axis of rotation, non-pinchable wala, yes, Stemmer's. So telos is mesenteric cyst. All right, so this is about all of these signs. Okay, last question. 35-year-old female with Raynaud's phenomenon, tightening of skin, dyspnea. So we are thinking of what? We are thinking of crest or scleroderma, है ना? Crest और scleroderma के बारे में सोच रहे हैं. तो dyspnea, bilateral basal rate. So this is associated with ILD. In fact, scleroderma has the highest chance of ILD with पीएच का सबसे मैक्सिमम रिस्क होता है स्क्लीरोडर्मा के साथ. Yesterday in Recipe Plus class we had discussed types of pH. So quickly let's do the Dana point classification of types of pH. So here in type 1 it is usually idiopathic or very miscellaneous causes. All right, so this is the idiopathic variant. Type 2 pH is when you have लेफ्ट वेंट्रिकुलर फेलियर, एलवीएफ के वजह से यू आर हैविंग अपस्ट्रीम डायलिटेशन एंड पीएच. थर्ड में क्या है? थर्ड में बिकॉज ऑफ लंग डिजीज. सो दिस इज टाइप 3 बिकॉज ऑफ chronic ILD के कारण when you are having PH, that is type 3. 4 is chronic thromboembolism. So CTE PH, chronic thromboembolism leading to pulmonary arterial hypertension. And 5 is miscellaneous or not specified. जो कुछ नहीं मिला वो type 5. Yes, in restrictive lung disease, ILD is the prime example. DLCO will reduce. So you will have FEV1 by FVC, which is normal to increased, and अब इसमें आप DLCO देखोगे, that will be reduced. Coming back to the question. So investigation of choice for ILD, it is HRCT chest, not echo, not PFT, not MRI. All right. So even though restrictive में PFT करने का मन होगा because we know the findings, but still the investigation of choice to pick up ILD, it's gonna be HRCT chest, because PFT में restrictive मिलेगा तो भी I need to see what is the kind of ILD, right? So we'll eventually go on to HRCT chest. This is the Dana point classification. This is very important, guys. PH, expect a question. You need to know this. Okay. Anywhere you have primary, secondary, it's the same thing. When you can't find any other cause, that's the only thing, that's primary Raynaud's. If it's associated with scleroderma or any other connective tissue disorder, that's secondary Raynaud's. As simple as that. Okay. All right. So we'll stop here. We'll meet quickly and we'll continue from this point onwards. So we have 20 plus 50, 70 questions to be done in 30 minutes on the app. So we'll try and finish off as many as possible and have one more class. Okay. So I hope this was useful. RGU versus MCU और करेंगे हम लोग. I'll show you more images if you didn't understand. So MCU will see a bladder which is dilated and you'll see the urethra. Okay. So we are performing it for bladder and urethra, whereas RGU is only for the urethra. Okay. All right. Thank you so much. Yeah, it's at 3 o'clock. In 15 minutes time, you'll find the link on the group itself. Okay. All right. Thank you so much and take care.